and this would be loss of control. So it'll either appear as urgency, frequency, urge incontinence. They may also appear with hesitancy, interrupted stream, or incomplete voiding and urinary retention. Another big thing that you will see is often influenced by the other symptoms is depression. So this is seen in about 2/3 of MS patients. The suicide risk is higher than the regular population due to the life expectancy being reduced 5 to 10 years, and this would be an important aspect of their care to think about when it comes time for treatment. Another symptom that we see often is fatigue. And this will be influenced by other symptoms as well, but patients will report an overall greater sense of fatigue than normal, or than they're used to. This is a pretty big one, and something that's important to note about MS is that there's really no one identifying symptom that you can use to say, like, this is for sure MS. But there are some that are more so characteristic than others, and this is one of them. So heat sensitivity, and I'm going to put this symptom in green because it's one of those important ones. It's called Euthoff's phenomenon, and that is spelled a little bit funny, so let me just take a peek here. Okay, so this is very characteristic of patients with MS. It's noted as small increases in the body temperature that worsens pre-existing symptoms of MS. So that's a big one to look out for. Okay. Along with this, we have pain, which I'm sure you would think of in many pathologies. But to be more specific to MS patients, we have neurogenic pain and musculoskeletal pain. So neurogenic pain, this is going to look like, this is going to be paroxysmal, persistent, or episodic. It'll come and go with their relapses or remissions, and this will look like burning or ice dysthesias of the feet, hands, limbs, and trunk. Let me just finish this. So to note, we have the paroxysmal ones. Okay, and this is another very characteristic of MS symptom, which is paroxysmal symptom. It's called Lermit sign, right here. This one's spelled funny too. Lher. Okay, and this is characterized as an electrical shock feeling that patients will feel when they retract their neck backwards like this. It kind of goes right down their spine and sometimes into the limbs. It's, I'm sure, very uncomfortable. And then we have the musculoskeletal. And, oh, I keep forgetting the last letter. And this will be seen as paralysis, immobility, or spasticity. And we can see like these are all making sense with our pathophysiology because we're demyelinating all of these nerves and it's disrupting the conduction. So it would be expected to see symptoms like this. Another big MS sign is here. It's called the anaconda sign or the MS hug. And this is characterized, they're the same thing. I'll put an or so that there's no confusion. Essentially, it's like a tight gripping, squeezing feeling that patients will feel usually in the thorax. So what else do we have? Then we've got the sensory symptoms. And this is gonna present as numbness, tingling, pins and needles, tightness, coldness, or swelling of the limbs and trunk. A big one here, another big MS sign is going to be the name of it. Oh, there is no name for this one, but it's important to note that it's intense itch that's always unilateral of their cervical spine, the dermatomes of their cervical spine. Okay. And I did read that it is possible for it to be bilateral, but that's really rare to see. Some of the other objective findings that you'll see are sexual dysfunction, and this again is going to relate back to the depression. So for men, you're going to see reduced libido, erectile impotence, the disappearance of early morning erections, premature ejaculations, orgasmic dysfunction, and reduced penile sensation. For women, the most common complaints are reduced libido, difficulties in achieving orgasm, decreased vaginal lubrication, decreased vaginal sensation, and dyspareunia. So lastly, we're going to have vertigo. Which the patient will usually report to as dizziness, types of feelings, either they're spinning or the room is spinning. And then we have visual loss. And specifically, we're going to be seeing optic neuritis. All right. So, optic neuritis is, again, unilateral pain that is accentuated by ocular movements, followed by a variable degree of visual loss, affecting mainly the central vision. Bilateral simultaneous optic neuritis is also rare. So typically when you're dealing with MS, it's a unilateral abnormality. Okay, and then on to the physical exam findings. Again, some of these are going to overlap, but it's important to note that there are no clinical findings that are unique to MS, just some that are highly characteristic. And we have two kind of unique things that overarch these symptoms, which are clinically isolated versus radiologically isolated symptoms. In clinically isolated symptoms or a syndrome, this refers to monosymptomatic attacks that do not fulfill diagnostic criteria for MS, but they may predispose to clinically define MS. So it would be something that would kind of pique your interest to question, does this patient have MS? And then you would have to back it up with MRI findings. And then on the other hand, the radiologically isolated syndrome would be MRI lesions with no clinical symptoms of MS. So you could have one or the other. But something that you definitely would see in your physical exam in a patient with MS is eye movement abnormalities. So we'll start that one. Oh, wrong color. Wrong, right here. Okay. Specifically, we would see internuclear ophthalmoplegia. Sorry, it's a big word. So, internuclear. We have room for it. Okay. And this is characterized by abnormal horizontal ocular movement with the loss or delay of adduction and horizontal nystagmus of the abducting eye. So that's a pretty big one that you could see in a patient in the office. Another one is pendular nystagmus. And this one's pretty cool because it kind of looks like quivering jelly in the eye. It's a rapid, small, pendular oscillation of the eyes. And